Good morning, everyone. Again, thank you for joining Signals and Symptoms podcast. Today, we have two special guests. My two co hosts, besties, are going to act as guests today. Of course, world famous Harvey Castro, who's going to basically be talking about a special topic that I prepared for today, which I need help with. And then, of course, Edward Marks, who is going to help us with essentially understanding how the care paradigm. So this is where the topic is. So, and I'm not going to give some updates today. We're going to keep it a little short today. The question is that we keep up talking about patients, we keep talking about AI and healthcare AI, and then it's going to change the trajectory of care coordination. But the minute the care coordination changes, the economics changes behind it. Like how hospitals going to rewire in the age of AI, how clinics are going to go rewire. And Harvey Castro owned a lot of EHRs in the past. If he were to build an EHR today in the age of AI, how does he think he's going to change? How is it going to change the economics of, let's say, building a new EHR or urgent care or whatever the case may be? And if I'm building a neurology clinic, how are things going to happen? So the basically what I'm trying to say, there's a twin disruption. One is, of course, the medical part of it. The other one is essentially how the cost reduction impacts, how the revenue growth changes, how the optimization completely changes as well. Now, a reminder that healthcare is also a business, and therefore business has comes with a lot of things, right? That how is it going to really change, and how do we see the future in 1 year, 2 years, 5 years, and 10 years as we go along. So, just to prime the discussion up, I'm going to give you two major, in my opinion, some observations. Number one, my sister is a psychiatrist. She teaches a lot of psychiatry residents, and then she now moved away. But what she had noticed is that essentially nearly 90% of her psychiatrist classes are moving towards, for a lack of a better word, concierge medicine, telemedicine, more importantly, essentially cash pay, and they have forgone essentially working inside the insurance scope completely because it's just relatively annoying, which creates a huge gap for Medicare and Medicaid patients as well. So that's observation number two. The observation number one, and observation number two is the rise of the wellness part. We talk about healthcare, 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 but essentially med spas, chiropractors, etc. All of them are now using labs, using imaging, and also now adding personalized treatments, including peptides, and then of course, essentially moving forward. By the way, Harvey, I have to introduce you to a few people who are looking at actually building a compounding pharmacy formulary, the first of its kind in pharmacy, to just build stacking peptides, because peptides are not easy to stack. You have to make sure that it's about testosterone, muscle growth, sleep, all of this. So all of that basically is now impacting. So problem number one, AI is disrupting care. Now we have started it. We have one use case that is AI ambient, and now of course with me radiology and ambient scribes, AI image analysis, and all of that is coming. How, number one would be that how it is disrupting the complete financial chain of the solution part. So I'm going to start with Ed. Reminder: Ed is actually board member of multiple hospitals. He has been a chief AI officer, chief innovation officer of Cleveland Clinic. He sits with many big people that I don't have access to, and he has been to HIMSS recently, and he has basically gathered both the emotional side of the leaders, which is very important, and then of course the implementation and the practical side. So Ed, again, I gave my spiel. So first, you can set the stage better than I do, and then let's start with the mega concept of U.S. hospital systems. Then we'll come to Harvey, which is basically global, what's happening, and then we'll peel into each layer of this smelly onion one at a time, because people don't even like to admit that healthcare is a business, which is odd. Anyways, go ahead.
Yeah, well, hello everyone, and good to be chatting on this topic. I think it's super critical for a number of reasons. And I think if you don't understand it yet, hopefully after this time together, we'll have a shared understanding. The Yeah, I think healthcare is about to be disrupted in a massive way. We talked about that in the past with virtual care, and of course, we saw it actually happen with the pandemic. But then we all went back pretty much to the old standard ways because that was the economics. So if you look at what's happening just this year alone, a Wall Street Journal had another article coming out uh, this week. Maybe it was this past weekend, and we can post the link or something. I can get it for you, where it's talking about how there's been four consumer facing products that have come into uh, reality this year alone. And they are completely going around healthcare systems. And no one's really paid that much attention because, we've talked about this actually, Junaid and Harvey, on here since the very beginning. No one really pays attention because it's kind of status quo. It hasn't hit their pocket, but yeah, but it's about to. And there was a quote from there. I'm just trying to pull it that, hey, we have to change our business models or be lost. When a general purpose AI can field health questions at consumer scale with no procurement chain. So this is huge. So think about this. There's four that came out that we're all familiar with this year alone. When a general purpose AI can field health questions at consumer scale with no procurement chain, no InfoSec review, no 6 month, and I edited out, they cited a specific vendor, but I just call it generic EHR vendor, no 6 month app queue permission, the implicit message to health IT buyers is uncomfortable. The friction we've built, right, hospitals we've built into our vendor onboarding process is becoming a competitive liability because we all know it can take. I was talking to a different person yesterday, 18 months. They finally went through all the governance structures and it took 18 months. And he said by time their technology was approved, it was obsolete. They had already come out with the latest and greatest. And so because we're so slow to adopt new things in healthcare, uh, so a competitive liability, not a quality filter, right? We've created these governance processes, we've created all these filters, all these reviews. It's a liability today. Maybe in the past it wasn't. So self-insured employers spending north of $1 trillion annually are watching employees get health guidance from Claude or Perplexity before their own benefit navigation tools even finish loading. Think about that. Even the employees of hospitals and people like us, we are using these tools. We've gave examples already. So because it's such a slow moving, right? Think about uh, Clay Christensen's, the innovation dilemma, all his books that he did. He did several on innovation. It's perfect situation where we're going to be disrupted unless we make changes right away. We're going to be disrupted by these outside forces. I named a couple already, and it's going to completely change the economics when you no longer have primary care, right? So I've been again, Junaid, as you shared my background with hospitals, the the way they work is you have primary care, and sometimes
Mhm.
you give away things like EHRs and things like that to try to get the stickiness in a legal, stark, compliant way. Sometimes you outright buy PCP practices, but the intent is you get all the PCPs you can, and then when something is wrong with the patient, right, they go to the specialist, and the specialist is associated on your medical staff, and that brings the revenue to the hospital
Mhm.
because they're doing the surgeries there. Now, if that PCP layer is gone, which it will be, and I've written a book about this, and people kind of laugh, but I think as they see all these new articles, there was another new one came out yesterday. When they start seeing all these articles come out showing that this shift is really taking place, um, that's going to be a huge wake up call. So that's, Junaid, kind of big picture, what's happening in the US based healthcare in terms of the economics are going to fundamentally change unless hospitals wake up now. I mean, it's there, it's too late already, but they got to do something now. The only thing I'll say, Junaid, I did, and I can't, I can't cite who it is, but I interacted with three of the top five, according to U.S. News and World Report, three of the top five health systems in the last 2 weeks. So you'll just have to guess because again, I'm not at liberty to say, but only one only one understood what we're talking about and was actually doing something. I don't know that it's going to be fast enough, but they were actually doing something. They recognized that the old way isn't going to work, and they had to take some risks. They had to take some bets with different types of companies and start working with them. Only one out of the three. So that gives you kind of indication where we know there's an issue, but very slow to move. And let me give you a second reference point, and then I'll stop. Another conversation with one of those three. Again, these are top 5 health systems in the world or United States, according to U.S. News World Report. The executive said, "Ed, you're absolutely right. I know it, but no one will listen to me." So, today, with that, I'll turn it back to you.
It's very amazing that you told the story about something that is insane, that even the employees themselves, including, yes, I mean, I have nurse practitioners who are not asking enough questions to me that like they used to. I have nurses who would just say, "Hey, I got this from ChatGPT. Do you agree?" And then they move on. It's kind of scary as a physician that that the reliance is on a tool that is not vetted. Now the problem is that another bigger problem, of course, FDA compliance, and we're going to talk to Harvey about governance and how it is changing. Because some of this needs to go into the money that you're going to save needs to go into governance. Otherwise, I don't know what the shit we are doing right now. Because as in prior podcasts, us about we're living in a wild, wild west. Now, coming back to Harvey, which has a massive international experience, where countries at the level of countries are basically changing their policies. And while we're living in the wild, wild west here in US, Harvey, give us a contrast of how things are changing globally in this context, and how, when we have an insurance-based system, privatized healthcare, but what happens in a public healthcare systems? How are they coping in this new reality where not just the care is disrupted, but economics are?
Yeah, so what I find fascinating is all of this to me personally, I feel like this ties to culture, right? If the US government and the culture of healthcare is a certain way, then the mandates, the everything that we're doing, the workflow is a certain way. Other countries have always done things differently, obviously, that's the culture comment. And so I find it interesting how the correlation plays into healthcare. Example, I went to Dubai, very strict. I loved it. It was really interesting, but it's a top-down effect. They're like, this is what we want to do. This is how we're going to take care of healthcare. And it's coming from the top, and it's being honored all the way through. There's no one saying otherwise. And I know there's two sides of that story. Some people are like, whoa, you're being too strict. And on the other side, it's like, wait a second. They are helping the country. They are creating digital twins. They have one electronic medical record. They're leveraging the data of AI for the entire population. And that just shifts the way healthcare is delivered. Obviously, what we're talking about, Ed explains, we have pain points here in the United States. If we didn't have any pain points, we wouldn't have international medical travel. It wouldn't exist. That the reason it exists is because there's such a problem here in the state. There's so much money that is, let's call it wasted, or it's not optimized. And as a result, other countries, some of these things can be 10 times cheaper than the United States. Case in point, I gave a TED Talk in Arizona last year, and I was shocked. Every single person I interacted with, every single one, I don't know why it came up, they're like, I go to Mexico. It was literally right next door. It was like 10-minute from where I was speaking. And I go, why do you go to Mexico? It's like, I get all my dental care there. I don't know what it was, but everyone I interacted with local, they were like, I have to go to Mexico for my dental work. And I thought, interesting, there's a zillion dentists here, but they're all not going there, you know? Anyway.
So true. I mean, even the traditional care that we are already experiencing is changing. I mean, we're going to see how the oil prices are going to change, but border towns in Arizona, where you can literally drive to Mexico, if you walk in, you're going to see dentist shops lined up like literally lined up on both sides. And by the way, highly qualified, American trained with American equipment at 1/10 of the price. So those who don't know, go to Mexico for dental work. But long story short, people are going to Turkey for hair plugs, and now way more. People are going to Philippines and Vietnam even to go through that. And of course, India is a very hot destination as well. Now, more importantly, we're seeing that investors see it. They are the total funding in digital health of 14.2 billion, 54% went to AI. So if you follow the money, which is essentially we think investors as smart money, which we don't know. But what I'm saying is that the smart money is going towards the AI. But then the clinical intervention versus economic drivers are different. So let me talk about this. So chronic care predictive analytics, which we were doing, and we send patients, etc., but reduce hospitals admission and protected DRG margins are gonna essentially fall, given that as I'm saying, that the middle of the pack people, right? There's like highly super specialized, neurocritical care, stroke, epilepsy, and then there is entry points. But the middle of the pack people are pushing up because the word I use is intelligence is democratized. So when actually demonetized, which democratization was very good, but demonetization is going to be a problem. So Ed, when you're seeing this and when you're talking to hospitals, that you are looking at the future where, first of all, hospitals are already cash strapped, right? I mean, the economics are not good, the margins are not good. And then now, sometimes the higher value targets are getting, away. I mean, just like the role of ASCs, ambulatory surgical units really crushed the hospital's bottom lines. Then we are looking at, now, pain clinics, etc., all of that. When you reduce essentially hospital admissions, good for the patient. Don't get me wrong. We love the patient. We love this. As a physician, we love this. But how are hospitals going to cope with it in the next 2 years, 3 years, 5 years?
I always said that they may sell off some assets and some of the brick and mortar
So
may
you're
become
really
community assets.
So you're going to recommend as a board member that you have to restructure your whole sort of play.
Yeah,
here.
think about it. If you're, again, I'm sure there's some hospitals that have a different system, but the majority, the PCP is the lifeline. And if that PCP, one of the predictions I've made, and we'll test it and we'll find out if it was right or not, that 65% of people will get 85% of their care via AI. And that's a significant reduction in primary care and in the traditional model. So who's going to tell those individuals, where they're going to go for their specialty care? In the past, again, you had the referral system, which was largely based on this vertical integration. And now there's going to be someone else potentially directing those patients. So that revenue stream will be significantly impacted. So yeah, what are they going to do? Well, one is, we've talked about this before, is they need to jump in the game. They need to offer bimodal treatment options. Again, the traditional brick and mortar will always exist for some patients. Two, they need to double down on the virtual care that worked so well during COVID. And again, why did we leave it? I think largely because economics. Third, they need to offer, these AI agents. They need to replicate what these other consumer grade products are now doing. That's their new competitor. It's not the hospital across the street or in the region. It is these consumer AI products. That's the competitor. So that's what's going to happen. They're going to have to either jump in the game and become competitive, or they're going to slowly attrit their primary care referral base. Revenue is going to get much smaller, and they're going to have to make some drastic decisions, like, mega chains, right? We're the only industry. Think about that. We're the only industry that I can think of that has more than 3 to 5 major players that have 80% of the market share. Take automotive. How many car companies are there? There's probably 5 car companies that are 80%. And it just so challenged me. I'm trying to think of another industry. Um, most industries,
Airlines.
let's see, airlines.
Airlines.
Airlines a great one.
Classic
I
one.
just watched a video. There was like a couple
Mhm.
hundred airlines actually, right? A lot of them were smaller regional ones. And today, yeah, there's like 5 that control 80%. So I think that's what's going to happen. So they're going to get even bigger change. We saw what recently Sutter and Alina, like that got that made a few people scratch their heads a little bit, just the geographic, you know, where they currently operate. But then you think about it the second time, and they're like, oh, it makes perfect sense because now they have huge geographical coverage. So I think you're going to see a lot more M&A activity for survival.
Wow. So basically, what you're saying is that hospitals will need to rewire, go from brick and mortar to more consolidated view of things, and then incorporate virtual AI, all of these as a funneling pathway.
Yeah, but you
While at the go ahead.
yeah, but and yeah, it's a beautiful summary. You're saying it much better than what I said. But don't forget that quote that I had in the beginning that came out of this Wall Street Journal chain that I was following, and that is, if we react, hospitals react the way we traditionally react, it'll be a couple years, and then it's too late. You've got to make decisions like that.
Exactly. I mean, to be honest with you, I'm just going to tell you in real world. I mean, it takes 2 weeks to get a freaking meeting. Like, and I'm building new modules on a 2-hour basis. I mean, you're going to see those releases. And next week, hopefully, we don't have a guest, and I'm going to show you exactly what we have done on Save Life AI. It is insane, like how fast we can move now, and how slow the adoption curve is because of the implementation issues. It's just, oh my god. Anyways, so funneling will change, and more importantly, you're going to see that more M&A activity, which is honestly, I'm just going to be honest with you, all M&A activity in healthcare has always been detrimental to patients. You get reduced access, you get increased pricing. That is a fact. And then this war between the hospitals and the insurance companies end up becoming a freaking issue for, let's just be honest, patients. Because what you're exactly saying is that what Harvey is saying, that if you have an urgent care closed or an EHR closed because of this process, we know AI is going to help, but at the end of the day, somebody needs to put the freaking injection in the patient's arm. And if that spot closes, then the economics makes patient care good or bad, because that's a really odd balance. We're going to go through this, which brings us back to Harvey. Harvey, let's say, assume you are even younger than what you look right now, because it's amazing how young you look still. Anyways, what I'm saying is that if you were to get into the game again as an EHR physician, and then build a new sort of around the shop right here corner, like EHRs with hospital privilege, like the amazing thing you did and then got exit. But if you were to restart this game, how would you do it in this new environment that we're in?
That's a tough one. I believe strongly it's about a win-win situation, right? Unfortunately, both sides of that equation are on opposite sides, and that the insurance wants to make more money for themselves, and the hospital wants to have the money so they can give to the patients. That's how I see it. So to me, it's how do you make that perfect balance? How do you lower the price of healthcare and still make it affordable and still profitable, so that people can still have their job? And so for me personally, I see it as we would need to put more predictive analytics. There's a retooling, I call it the great shift. Individuals that spend X amount of dollars, like you and I did for our education, we would like to be paid a certain amount so that we could pay back our student loans. But let's shift that for a second. What if our medical education didn't cost as much? What if our debt wasn't as high? Could we lower the price of all things moving forward? So I think that's where we're at. I love what Ed said about the percentage. 65% of people will get 85% of the care. Well, with AI, if that's the case, then you would think, why not lower the price of healthcare? But then there's that dichotomy, right? If I woke up one day and I said, hey, Janae, I'm only going to pay you 10% of what I used to pay moving forward, you'd be like, what? So there's that disconnect.
And that's I mean, if you look at the macroeconomic picture, it's kind of insane that 18% of GDP goes to healthcare. But more
Yes.
importantly, 18% of GDP goes to healthcare, providing jobs which are going to buy the car, the toothpaste, the toothbrush too. So what I'm saying is that this is not a joke. I mean, think about it. I mean, if you look in your family, there's really, I have not heard a family member who does not have an healthcare in their professional in their family. So now we come to this conversational agents AI. We can one more thing, and then this is the AI workforce paradox. So I was talking about the protected core, like the paramedics, the registered nurse, emergency physicians, orthopedics, where the tactile, that the word is tactile input is important, and that's a better word to explain it. That when you're talking about really looking into these things. However, you can see that the automation target is 40% of healthcare skills are high risk of automation, 40%. And this is not really the front office, the coding compliance, the back office. And they have real numbers that we are sharing here that is going to basically, really change. 92% of our team leaders know that this is the top priority. We're going to get the AI done so that the AI wars begin again. And then the idea is that we are going through this $740 billion that are spent in admin and going through that. And the payer provider AI arm race that I keep talking about is that this is going to essentially impact this. And then lastly, just wanting to pull this up, and then I want to talk to now again, Ed, that rewiring value-based care, VBC, which is your favorite topic. How do you envision if you let's say you're the king of the world, and then now you're going to create a new policy for VBC for US, where the economic realities are changed, including AI and everything. We do have some issues with data which are constantly getting done, right? We just ONC released one update. We're getting access to more EHRs. By 2027, shit is going to hit the fan. If you're not going to do it, they're going to start enforcing it, all of that. Presumably the data silos are going to move away, which is one of the biggest reasons that we are not able to move fast. But let's assume that is done. How would you reconstruct value-based care in the age of AI? You guys have to answer a call.
Well, going back to an earlier statement about consolidation on the hospital side, insurance companies are a little bit more consolidated. I haven't run the numbers, but if you did, like, how many insurance companies represent the top 80%? It's probably, I'm guessing, maybe in that 5 range. But that said, where Summa Health is located in mid-Ohio, in that county, there's over 30 different health plans. So there's still a lot of health plans out there, and I'm not an advocate, so we don't get into politics here, at least I don't. I'm not an advocate of a universal payer system, but certainly if you wanted to do value-based care at scale, it would be nice to have it would make it easier if there was a single system. But what can happen, let's just say it's regionalized, and again, it's not even regionalized, because the example I give you, Summa Health has its own payer, and we compete against 30 other payers for the same patient in this mid-market. It's crazy. So that's part of the economics and why this is so complicated here in the US. But let's assume, so going back to answering your question, let's assume you're in a situation where you do have a single payer that covers the entire geography. So obviously you would deploy these same AI agents that we've been talking about, that I've referenced. There's 4 major ones today that are being used, and not only are these 4 major consumer scale AI tools out there, but I already mentioned in previous episodes, there's other actually companies now offering these. Of course, it's great marketing. You come in free. So they're saying you can be part of our insurance company. Basically, you get all your care free, and there's a physician in the loop, which is another topic for another day. That do you really need a physician in the loop? Why would you want that? If today we're killing 100,000 people a year in our hospitals, I don't know why you would want that. But 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 for that example, they have a physician in the loop to make everyone kind of like feel good about it. So you have all these disruptors. So you would have to become the disruptor. So that's how I would answer the question. What would you do in a VBC scenario? You would become the disruptor. You would offer multi-channel, omni-channel type of healthcare, including these agents. And if you did this, and if you really incentivize your patients to move this direction, I mentioned 65% of patients. If you could even move that to 80% of the patients through incentives, through efficiencies, there might be some natural incentives that come if you're just more efficient. That's how I would do it, is the deployment of these agents. Then you no longer think about this. Right? There's a struggle with healthcare today, right? And it's kind of a weird dichotomy. They have 3 months, 6 months waiting for specialists, in some cases primary care. So they have demand, but they don't have the capability to take them. But if you had these AI agents that, again, people are using now and are going to use a lot more, you would then be able to move your access issue would be gone. Your PCPs that still needed would be very well employed, and the other ones would start doing specialty care. Because as we know, a lot of PCPs talk about the fact that they're just air traffic control. I mean, in almost any, and I mean this with all respect, AI can do that, traffic control, right? That's easy. So then the PCP can move up chain a little bit and take care of patients that need to be seen, take care of patients, that need some specialty care that don't really require a highly trained specialist. You can reserve them for their highly trained thing. Again, think about the access issues. They would be gone. So answer to the question is, AI agents taking a lot of the primary care. That's the first thing right there. You'd become so much more efficient. Access issues would be gone. Quality would go up. Experience would go up. Costs would go down.
Perfect. Love it. You're absolutely right. The pathways are going to be adjusted as well. Direct to specialty versus PCP to specialty versus, concierge medicine. And then one of the things, Harvey, I want to understand, because you dabble in a lot of different technologies, even more than I do, as we are looking at, that's my thought. Please don't take it. It's an opinionated. We're going to basically move to what we call a tokenization economy, including, I think, US dollar going to convert to stable coin at one point or another in the next 2 to 3 years. And we're basically going to see, for a good or bad, I don't care. But at the end of the day, essentially tokenized economy that is digitalized completely end to end. And then Harvey, what Ed said, one of the biggest problems was data silo. So data flows silos are breaking down. But more importantly now, the measurement problem, like in VBC, value-based care, the biggest problem is measurement, that how Junaid Kalia is actually improving. And more importantly, if he's improving because he's a freaking smoker, or is it that the doctor did not take care of them? So the question really becomes is that Harvey, how do you envision the tokenization of economy in general? First, I need your opinion on it, because I love to always have your opinion. And then more importantly, how do you think that will this tokenization be part and parcel of a VBC architecture, and who will own it? That's another big problem, because that's another biggest problem for US, I think, at the end of the day, is this, that no centralized medical records. Well, let's say we assume that we got through this. How would you centralize virtual VBC measurement through tokenization? Or I'm just hallucinating?
Oh man, it sounds like you're going down that path, and it's an interesting path. It goes back to what I kind of say always. It's the culture, right? That's radical. That's different. Will the culture accept it? Will the older generations of the people in power allow that to happen while they're alive? Let's just call it. Or will it be our kids or grandkids that see differently, and they will create that culture, and they will push the laws and create that to become a reality? With that said, there's many ways that there's like hints of that coming, right? You look at insurance company rewarding you for better health, going to your annual visits, moving around more. Those metrics, the insurance company is saying, okay, you know what, we will pay you by decreasing your premiums. We see it in the automobile industry with Tesla now saying, hey, if you have one of our cars and we're insuring you, we will lower your rates. And we see that in other car industries saying the same thing, like, hey, you're a great driver and you're not even using your car that much, so we're going to lower your price even more. So that in a way is tokenization, if you think about it. Who will own that pyramid? It'll be interesting. Just because the way I see it is the powers are not going to want to let go of power. I would assume that it'll be the government pushing hard to have some hand in that, so that they own it. And then obviously the bigger insurance companies are going to make sure that they have their hand. What do you think, Ed?
Yeah, I agree. I think that's a great analysis. I think that's, and I didn't know about the car insurance. Yeah, that's a great example.
Well, I'm just gonna say it. Ed is gonna own it. Okay, guys. Ed is gonna say
Ed's gonna tokenize it.
Yeah. So here's the thing. I'm actually gonna have a separate video on the cost trap of AI, how the compute cost is gonna be scaled down and everything, especially now that, by the way, I think we need another sort of my professor lectures discussing NVIDIA's acquisition of Grok, GROQ, essentially integrating GPUs with LPUs, which are inference engine. And this thing is going to basically become not a problem, very near future. And then we have the current friction, the high friction removes operates per user basis. Then we're getting the regulatory checkpoint, and FDA has actually, opened up CDSS, and we're seeing that CMS will mandate, which my opinion is, and this is my slide, that the value-based care will be parcel and parcel of it. Now, how it will look like, I don't know, but this will be part and parcel, especially considering previously that 740 billion is going to be hopefully saved, and this will also create a real mechanism for a new form of reimbursement. That is, AI is always present, monitoring the care. AI is tokenizing it, and then you are being reviewed. Which again, now when I think about it, my developers, we are organizing and measuring how much code they push, everything. Doctors have had a very good life in that regard. So coming back to his point that we are going to see significant pushbacks in this generation, but then as we move along, generation is going to change. So reality check's still there. We only have 30% of healthcare systems operate Gen scale AI. Only 2% have true enterprise. So we have a huge market to actually conquer. BCG is that will experience high profile failures in 22-26. Again, we are still in the wild west phase, and we're going to experiment and improve it and find the right balance. But again, I just wanted to make this important distinction that AI is no longer just a clinical tool. And what you guys need to understand, in my opinion, at least this is a new reality for me to understand as well. And not just as people say, well, you're a startup and you have a bias, and I get it. I do. I have a freaking bias. And that's what I'm doing, right? I mean, I'm going to a hospital system and saying, use the scribe in a way, because then we're going to literally give you real-time information that, RCM analysis can be done, and therefore you should buy it. And that's why they're buying it. Yes. I mean, this is a reality that I'm telling you right now that is happening, which is basically analyzing physician in real time, their performance and documentation, how good it will be for an RCM analysis. Like the whole paradigm is shifting. So those are my thoughts. Again, some stupid comments. So I'm, as usual, my besties always correct me, and I like to be corrected live in front of people. Because again, I would have a blinder, right? And that's why Ed and Harvey are my advisors, and that's why I love them, is because, hey, these are, so whatever I just said, what was stupid about it, Ed and Harvey? Oh,
Well,
No,
go ahead, Ed.
go
No,
ahead.
go ahead, buddy. No, but you go
I
ahead, buddy.
yeah, I think you're spot on, and it's great to hear from a clinician point of view. And you live it. You're one of those that I'm talking about, where you have this great product, and it can help hospitals to become more efficient, and um, I think it's spot on. But the middle, you had sort of three quotes in that last slide. The middle one doesn't bother me at all. The BCG. I think you attributed it to BCG maybe, because we already have tons of failure today. That's the thing that gets me, and it's something you said earlier, and I wanted to comment on, Junaid, is that some people push back saying, well, it's not perfect, it doesn't work all the time, whatever. Neither does healthcare today.
yes. Oh my God.
So
The
do
third
not use
biggest
that.
killer of patients is the healthcare itself. So
Yeah, exactly.
people
All right,
forget that.
I'll kick it to Harvey.
Yeah, no, I love this time that we spend together, because it personally makes me self-reflect on what's going on. And I love hearing from you guys, because it's different parts of the industry, yet we are similar minded, yet we see things differently. So we have great conversations. So for me, what I'm seeing and hearing just reinforces kind of, our mission, right? What we're doing, why we do what we do, why Junaid does Safe, with his company, and Ed and myself. I'm really, really stoked, because in the end of the day, fast forward, me working for Phantom Space, being able to see this technology, what we're doing, and how we can influence certain things, it helps, because now I'm able to talk to you guys and be like, hey, we should do this as a future project that we're all working on. So if anything, I really appreciate you guys.
We're gonna have another episode
You're on
soon
mute, buddy.
talking about. Oh,
Junaid.
am I?
But Ed, go ahead while he unmutes.
Ed is.
Well, no.
Ed,
He's
go ahead.
lost. You're mute.
No, I was saying, Junaid,
and you're
I can
mute
hear
too,
Junaid.
Ed, or is it me now?
It's you.
No.
Oh,
you.
it's probably me now.
It's Harvey. So go ahead, Junaid.
You guys keep going.
So I just want to clarify the intent of this
Yeah.
episodes when we impart sort of our understanding, when we talk about all of these things. And as you can see, the comments are pouring in as talking about, by the way, Vinod Khosla, 5 billion Khosla Ventures, has predicted this. And then I really thought that, the godfather of AI said that we will not need radiologists. And all of that had been a real annoying issue. And then now recently, I'm just going to say that this is now reality. I truly believe what Ed said is true now. And that's starting this January, by the way. Just to let you know, because the cycle has gone so fast that we have seen the movement of is very. Harvey, you have to mute yourself. So what I'm seeing is that truly agree with Ed, truly agree with Harvey. The whole point was there is AI is not just a care coordination or just care beneficial. It is going to truly disrupt your bottom line, your pocket, and you need to understand this as well. Therefore, you need to adopt it. That's the whole point. And number two is that we're going to see. Yes, I truly believe that PCPs are going to become more specialized, more better. And then the current PCP jobs, which is the air traffic controller, is going to go to APP plus AI or nurse practitioner plus AI. Agree with Edward Marks. Radiologist is going to become a real problem. As a matter of fact, their RAD partners and everyone are changing the reimbursement system from number of studies read to number of time spent, so that they decrease the overall cost of reading. That's true. That's going on now. And then lastly, I truly believe that we're going to see a tokenization of the healthcare economy in general. Basically, the idea would be that the back office, the front office, as it gets automated, the whole process is going to come forward more further, that you will be able to use quickly where to send, how to send, and AI can help coordinate care with you. Again, I'm very grateful to my besties, Ed and Harvey, to join us. Thank you, Ed, again, 6 a.m. I'm grateful to you as usual. you're always at some different time zone and still come to this podcast diligently. We are going to have two more episodes. One of them will be where Harvey's going to discuss just digital twin in general, and then digital twin in healthcare. So we're going to work on that. And then the second big episode that we're going to just the three of us, because that's, I believe, truly is going to be one of the key technological beneficial for humanity as well. And then we're going to have these sort of more engaging ones while we bring guests as well. So we just want to give you guys the flavor of guests. If you have some guests recommend, if you think you should come up and talk about this topic, you're more than welcome. Ed and Harvey, any last thoughts?
No, my favorite phrase, because I get this question a lot. It's like, hey man, how do I get better at AI? And I'm like, it's like riding a bike, right? The more you use it, the more you know it. At first, you freak out holding that bar really hard, and then later you're like, oh dude, I could ride this bike without holding the bar. So big picture, enjoy AI, do it in everything you do, because I do it for everything. I'll set aside a real quick story. My mom was here visiting me over the summer. Big crash in the bathroom of glass, and we ran in there and we're like, what the heck happened? And my mom said, get your camera out, take pictures of all the glass, the different angles, upload it to AI and see why this happened. My mom. And so basically, long story short, it was some interesting dynamics I'll tell you guys later. But the skinny, use AI.
Ed.
Yeah, I hate saying I agree all the time. That's not a good thing to say, but I agree. That's really good. And yeah, if I had time, maybe next episode. I don't want to waste people's time me trying to getting the video, but I got a video last night. I'm in Arizona visiting my dad, and I was with my dad, 91 years old, and his girlfriend, 86, who met online, and probably leveraged some AI doing that. But anyways, we were talking about AI. They were asking all sorts of questions. We were in a hospital setting, and they're into it. And so, man, it is a thing. It's real. And you either, I used to always say innovate or die. We'll have to come up with something clever like that for AI, or maybe it's AI or die.
Perfect ending. We should put that in a banner. Age is no longer a barrier for usage of AI. As a matter of fact, believe it or not, I've seen people who are at more extremes of ages more acquainted and malleable to use AI as compared to the middle road, which is a working class with their own biases that AI is going to take my job and everything, is more skeptical. Thank you guys for joining. See you guys next week. Have a nice wherever you are joining us from the world. Thanks.